Now, we did our no BP, no PP, we'll get rid of that. We did our AKI, I erased that, and we still got a little bit of love. Okay, now, it doesn't really matter if it's acute kidney injury, chronic kidney injury. Wouldn't you agree that once you grab a renal packet, the first thing that should have came to your mind was daily weights? Okay, so it doesn't matter which one of these they have, right? And we even say a little bit more about that. We say that any patient with any kind of organ failure should be on daily weights. Heart failure, kidney failure, liver failure, boom, daily weights. So far, so good? Okay, so as we venture a little bit forward here in this lecture, we are now talking about who needs dialysis. Of course, acute kidney injury needs dialysis, but so does end-stage renal disease, right? So that would be your chronic. Now, this AEIOU stuff, I like it because essentially it's telling you what could damage the kidneys or what kind of people could get into trouble with some problems that require dialysis. You know acid-based problems require dialysis. What kind? Acidosis. Metabolic acidosis. And how could you possibly get into trouble with that? Well, you could have a situation where you are in DKA. You could have a situation where you are in AKI. So the acute kidney injury patient will definitely have some acidosis, okay? Now, when you look at electrolytes, there are patients who come in with their potassium so high, and so high is 5.8 or higher. So high that they just need dialysis because insulin and everything else ain't gonna do it fast enough. Okay, there are those patients that come in like that, 6s and everything else, about to die, right? You grab the EKG and everything because you knew this is bad. So those patients with that ridiculously extremely high potassium, of course, would require dialysis. But that's not the only patient that will require dialysis. Patients with any other electrolytes that are really high, magnesium, calcium, phosphorus, whatever. If it's really high, it's got to come off, dialysis, okay? Now you look at intoxications. This is poisons and toxins. When you poison and give somebody something toxic, whether they overdosed on a bunch of medicines, or the kids drank antifreeze, or they swap, what is that? What is they doing? They stupid asses is doing pods, Tide pods and shit. When you're doing all that retarded stuff, you are shutting your body down. Poisons and toxins may require dialysis, okay? So you knew that. This is not like, kindergarten. Okay, now look at the overload of fluids. Lord knows that a fluid volume overload is a reason for dialysis. This is usually the patient who missed their dialysis appointments, correct? Now let's remind ourselves what's going on with this fluid volume overload. Since you doggone sure better know your select all and everything about it. So if I have a fluid volume excess or fluid volume overload or circulatory overload, boom, I am going to have classic hallmark symptoms. We do a methodological approach to how you figure this out. We teach you go from head to toe. So let's do it. What's going on all up in here? Headache. What's going on all up in here? JVD. Now remember, in the head department comes respiratory. What's happening with that? Shortness of breath. What about your respirations? Increased or decreased? Increased, because it's hard to breathe with a lot of water on your body. Y'all feel me? Okay, so far we got a little headache, we short of breath, we got increased respirations, we got JVD. That was all up and around in here. Let's walk the body. We in here now. Crackles, very nice, crackles. What we got going on right here?
Blood pressure.
High blood pressure. Doesn't volume control blood pressure?
Yeah.
Now let's move on down this arm. What's the quality? Bounding rapid pulse. That's called tachycardia. Bounding rapid pulse. Anything all up and around in here? Ascites is possible even when it's extreme though, right? It's not gonna be typical. Make sure you know it's not typical to have ascites. But if you do, that's extreme. That's extreme. You'll see that with extreme heart failure, extreme liver failure, right? So if it's extreme heart failure, which kind of heart failure might give you ascites, right or left? Right. Mm-hmm. Okay, let's keep it moving. What we got going all up and around, down up in here? I do. Mm-hmm. Now, we did daily weights. The patient had some issues. We did some daily weights. So included in your fluid volume overload is weight gain. Let's take this a step further, shall we? You did what blood work on this patient? What did we run on everybody, shit? CBC. Do we need a diff? No, there's no infection. We need a CBC. When we got a CBC, was the H&H high or low? Explain. Antonio, explain. Why is the H&H high?
The blood volume.
Explain. Janae, explain. Why is H&H high? I'm asking Janae.
Increased fluid causes volume increase.
H&H for this patient, is it high or low? Eddie.
It's going to be low, but it's diluted.
Thank you. The H&H is actually dilute. You got so much water, your blood ain't even deep red no more. The H&H is actually lower. Be careful. Think it through. If I don't have any water in my body, my blood is thick. My H&H is high. You gotta know this. Suddenly your fluid volume overload patient is giving you pink, frothy sputum. What's wrong with them now? Pulmonary edema. Extreme, right? That's a late sign. Pink, frothy sputum, late sign, pulmonary edema. They could cause, all this fluid on the body could cause another organ to fail. If it's kidney failure, it can lead to what? Heart failure. Yes, say it with your chest. Don't whisper, little babies. Okay, y'all good? Y'all all right with this? I hope you're learning some shit. All right, now, so that's that. Flip the page. And we have this pitiful lady, don't we? She's looking happy though. Oh wait, you know what? Go back to that AEIO. I want to give you one more thing on that. I want to talk about dialysis a little bit for the acute kidney injury. Let's say that your patient came in and they were getting a cardiac cath, they were diabetic, they were on metformin, and you were boo-boo the fool. Stuck on stupid, parked on dumb. Not my babies, somebody in the streets. Okay, so they admitted this patient, 53-year-old, cardiac catheterization, they're diabetic, they took their metformin, nobody told them not to, boom. You didn't even ask what meds they were on, you just prepared the patient for the little cardiac cath, put the 18-gauge IV in at a 15-degree angle, and you think you ready. You ain't asked her nothing about no metformin, you asked her what med she was on, but you didn't ask her if she took it. Are you still with me? Now, what do you know about a diabetic? What's the number one complication? Kidney what? Failure. What is contrast dyes? Toxic. What is metformin? Lactic acidosis if you order it when you do the contrast dyes. But you don't know none of this because you went to a shitty school and never saw me. So you got this patient, you didn't admit this patient, she's getting ready for her cardiac cath, she gets her cardiac cath, and she goes into AKI based on diabetic status and shitty kidneys, metformin not picked up beforehand and she took it that morning or the day before, and the fact that she had contrast dyes, which is extremely toxic to the kidneys. That's what you got. Now you get this patient, she's in acute kidney injury, she now needs dialysis yesterday. Does she have time for y'all to put an AV fistula and all this stuff that goes in people when we're doing chronic kidney failure? No. So how are we going to do her dialysis? Through a central line. It's going to be called continuous renal replacement therapy. So far so good? Continuous renal replacement therapy. done in the ICU is going to be a Quinton catheter. It will have a red and a blue port. So I'm going to write that down. Quinton catheter. It will have a red and a blue port. It's in the subclavian, so it's a central line in the subclavian. Is it tunneled or non-tunneled? Non-tunneled, because you had to put it in right away. You didn't go to surgery and get a port and all this. It's a non-tunneled central line. It has a red and a blue catheter, a red and blue port rather. What does blue usually mean in a textbook? Does it mean artery or venous? Venous, you better remember that. What does the A mean? I mean, what does the red mean? Arterial. So question, if we have a patient and we have a red and a blue port, does the blue port mean from the dialysis to the patient or from the patient to the dialysis? Venous. Which one of those does it mean? Does it mean dialysis to patient or patient to dialysis? What does it mean, Janae? What does it mean, Rhonda? What does it mean, Shiva? What does it mean, Cynthia? What does it mean, Felicia? What do you think it means, Katie? Dialysis, the patient wins. Remember, venous to the patient, artery away from the patient. You're gonna screw something up in this damn ICU you wanna work in so bad. You need to know this Quinton catheter, this subclavian central line, red and blue port, blue, dialysis to the patient, red, patient to dialysis. Okay, all right, now, so that is dialysis, right, for that patient. Now, you're the patient, you're the nurse in the hospital, you get the call that the patient needs dialysis. What types of things do you need to do to prepare for dialysis? Well, number one, if it's a diabetic like this patient was, you're going to make sure they eat really early. They're going to eat an early breakfast. Right before dialysis, they'll get their insulin. Why? Because dialysis increases blood sugar. You're going to hold medications. Certain medications this patient cannot have. Let's see if you know your shit. Give me a medication they can't have before dialysis, y'all. Rhonda? What can they not have before dialysis? What you gotta hold? You just said it. Metformin?
No.
Shiva? Oh, blood pressure. That's good. That's better. Blood pressure meds. Shiva, give me another med they gotta hold.
Anything that vasodilates?
I need a medication. Rachel, give me a medication. Okay, you said BP meds already. Beta blocker. Give me a medication you gotta hold, Kim. Metcalf? Anticoagulant, you need to sound like a nurse. What is you doing? Blood thinner. Sound like I'm kinsman. Okay, what you got, Rayshana? What you got, Brianna? What you got, who is that down the hall and through the woods? Baby girl, I wrote your name down today. What is your name? Tatiana. What do you got? What are we holding? Y'all pitiful. Katie. Dariana, no. Aha! There go my baby. Water soluble vitamins. That sounded cute. What the hell is it, Dariana? Give me some water soluble vitamins. D. She loves the D. You didn't get that right. Okay, what you got? No, I said D ain't it. You still saying the shit. Eddie, water soluble vitamins. All your B's and your C's. Get your life together. ADEK is fat. Addict, fat. You can have those before dialysis. So you held blood pressure medications like beta blockers, ACE inhibitors, whatever. You held anticoagulants, we won't figure out why. You held water-soluble vitamins because you knew we taking water off the body. We're gonna take them too. Give me some more love, Stephanie. What else we holding? Janae, what we holding? Eddie, what we holding? Y'all didn't get the main one, the number one. Ola, what's up? Say it loud. Digoxin. That's the main one, y'all. What's up? Now, Cynthia, big bad and bold. Why'd you hold the ditch? No. Why did she hold the ditch, Sarah? Why did she hold the ditch, Felicia? No. Josh. Why did she hold the ditch, Dariana? Glad y'all here. Janae?
Because if you're pulling off all the fluids, you're taking K with it, so did you be toxic?
Exactly. If you have a dialysis patient, you are removing fluid from the body, and you're also removing potassium. When potassium is low, DIG is high. When potassium is low, DIG is high. Now, peep this. You know about the water-soluble vitamins. You're taking water, you're gonna take the vitamins. Why did I hold the anticoagulant? Harjo, why did I hold that? Why did I say no, baby? Don't take your baby aspirin. Don't take your Coumadin right now. Why did I hold it? Monique, why did I hold it?
Because if you give the patient the anticoagulant, like brain, they're still gonna take you back to get to the dialysis.
When we prepare you for dialysis, we give you heparin. We don't need you doing double whammy up in here. So we have to hold whatever you're on because we know what we're gonna do. We can't afford for your blood to clot at dialysis, so you're gonna get an anticoagulant then. So we better hold whatever you're doing. Make sense? Okay, now, you said blood pressure meds. Is this list complete, or should I add one more category of drug? What else could I hold? Think about this. It's related, but it's not that. Toya, what you got? What you got, Ola? What should I hold? Isn't that already up there? I said blood pressure meds. It's another category of
Calcium
drug.
channel blocker?
That's a blood pressure med. It's another category. What'd you say, Rhonda? What else should we hold? Diuretics. Excellent. Isn't every patient on a diuretic? All these patients on diuretics, aren't they? You better hold it. What do diuretics do? Take your fluid, your potassium, and your damn blood pressure and drop it. You're gonna crash the patient if you don't know this. Okay? Now, when we do dialysis, our first nursing action after dialysis is check the blood pressure for obvious reasons. When we do dialysis, the first nursing action is to check the blood pressure for obvious reasons. Your patient could experience all kinds of problems. Dialysis is extremely bloody. Do something wrong, they can hemorrhage out. Dialysis is also unfortunately done in institutions where you have people that are trifling. 99% of all dialysis centers are wonderful. My father goes to one. 99% of them are wonderful, good, wholesome people. LPNs that care, RNs that give a shit. But every now and then, you'll get a dialysis center where there's a million call-offs, the people are not as, conscientious, management don't give a shit, it's all about the money. I don't know if you noticed, but a dialysis center is going up on every single corner of America. They even got them on the cruise ships. Well, that's nice, but if you don't have conscientious people, the kind with integrity, when you get call-offs, you still got all those patients to see. So now what are you doing? You're flipping the machines too fast because you ain't got no help. So you ain't cleaning nothing real well at all. And when you're not cleaning these machines really well, the dialysis patient gets hepatitis B and C. Hepatitis B and C, particularly C. If you don't watch your personal protective equipment and protect yourself, this is how the nurses got Ebola. Because with Ebola, dialysis is done. It's a very bloody procedure. They did not protect themselves well. They did not know how to remove PPE, and they got Ebola. They didn't know how to put it on right. They didn't know how to take it off right. They got Ebola. You have to remember your infectious disease principles and how to protect yourself. Okay. All right, so dialysis, right? It's not without risk. It's got a lot of things going on here. You could go into a hypotensive crisis. You could become fluid volume deficit. Shock, you know that. You could have something called a disequilibrium syndrome. These are the new patients that get dialysis. They're not used to it. Disequilibrium syndrome. My father experienced this. So disequilibrium syndrome means that the dialysis is too strong too fast. We're going to have to adjust the rate. This is a brand new patient. They're not used to all this. Or a pediatric client. Disequilibrium syndrome. So we're going to have to slow things down. Okay? Now, how would you know? How would you know the patient has this? They're dizzy, they get a headache, they get nauseated. They can have a seizure. Hopefully not, right? We want to catch it early. Your first action, stop the dialysis. Notify the doctor so you can get a prescription or an order for mannitol. Because the real issue here is the patient's going to go into cerebral edema. So the patient, again, the blood pressure drops really fast. They're going to get dizzy. They may even get a headache. They're definitely going to get a headache if it's later in the process. They're going to feel nauseous. They're going to be looking all crazy, anxious, restless. They don't know what's going on. They don't feel right. Okay? The patient, your job, first nursing action, stop the dialysis, notify the doc, get some mannitol. Mannitol is an osmotic diuretic. Okay? All righty. Flip the page to the lady still smiling.